All right. Is everybody able to log back in? Don't know what happened there. So the CDC recommends that you do not share blood glucose meters with anybody else. Each individual person should have their own blood glucose meter, even if it's two people in the same house that are family. That way it gets calibrated and you know that it's your meter. You want to clean and disinfect the blood glucose meters after each use. And then use insulin pens, your medication cartridges, or syringes on only one person at a time. Again, these flexi pens, the cap comes off and there's a needle, and then you'll dial in the amount of insulin that you give according to the sliding scale or what the glucose AccuCheck is at that particular time. So treatment for diabetes, it's a little different. Type 1, we're going to use insulin. We're going to use those rapid acting, short acting, intermediate acting, or long acting. For type 2, we're going to use oral anti-diabetic medications. Your first two first line drugs are going to be your metformin and your glipizide. Metformin is the first line medication that they typically prescribe for patients. There are some complications with the metformin as well because it does cause some diarrhea, and then there's a compliance issue. We're going to talk about the insulin first, and then we'll talk about some of those oral anti-diabetics again. So I put in here a chart for your type of insulin, whether it's rapid acting, short acting, intermediate acting, or long acting, and then your onset, peak, and duration. So why is that important? Why is it important to know the onset, peak, and duration of the different types of insulin? Nobody has an answer? Anybody want to speculate? So we want to know the onset, peak, and duration of the insulins because we want to make sure these patients have eaten. And we also want to make sure that we're going to reassess them. Remember, anytime we do an intervention, we're going to do an evaluation. So we want to make sure that we go back and assess and we make sure that they don't have any signs and symptoms of hypoglycemia. We use our rapid acting, the Liz Pro or the regular insulin, and we make sure that's what we typically cover them when we monitor AC and HS. So, and we want to make sure that they get a meal within 30 minutes or at least a snack to make sure they don't become hypoglycemic. The duration of that medication and the peak of that medication, you can see is 1 to 5 hours, which is why we do it AC and HS. So it's about every 3 to 4 hours, and it's in between that peak time. The duration is 6 to 10 hours. And you'll see with some of your long actings, those can last up to 18 to 24 hours. So your Levemir is one of your insulins that comes in the auto jet, and it lasts about 24 hours. So it's typically dosed once a day. So the duration and the peak of the medication helps the drug companies and the doctors with the dosing. So you know that they're getting a steady flow of that insulin. So nursing interventions for diabetics. We want to monitor their vital signs because what are some of the complications of diabetes? We talked about high blood pressure. We talked about cardiovascular disease. We talked about elevated triglycerides. and renal function. So our vital signs can assess our cardiac, our respiratory, and our renal function too, right? Because if we're hypotensive, that could be we got too much output or we have too little output. Monitor their eyes and nose. Again, for those kidney functions, high blood pressure. We're going to monitor their skin integrity because remember, patients with diabetes tend to have dry and cracked skin. We're going to educate the parents on the signs and symptoms to monitor for, especially for that hypoglycemia and hyperglycemia. Educate to wear medical alert bracelets. What happens if this child is out at school on the playground and passes out because he's now done a lot of exercise? We need to make sure that this patient and everybody knows that this patient is a diabetic and to check for a blood glucose. Provide nutritional guidelines. They might need some help with meal planning. We do meal planning and carbohydrates and proteins individually for the growth and the development of each of the different patients depending on their age, and it's individually. So these patients may need to see a diabetic educator and a dietitian that specializes in diabetics. Assist parents and patients to develop an exercise plan. These patients still need to exercise, right? They're not going to be sedentary. They're kids, right? They're going to run around. And then those insulin dosages may need to be adjusted according to how much exercise they're doing. Educate to monitor for illnesses and avoid those if possible, because we know blood glucose can raise when somebody is sick or in the hospital or has an illness. Doesn't mean we stop giving our insulin or doesn't mean we personally adjust the doses, but these patients may need insulin doses adjusted according to whatever illness is going on, because we know those illnesses will elevate blood glucose. We want to tell them to count their carbohydrates and eat regularly. Can everybody still hear me? Y'all with me still? Yes? No?
Yes.
Okay. All right. Because I'm getting some emails about they're not hearing.
Yes.
So I'm just making sure everybody can hear. Okay. So we want to educate these parents to count their carbohydrates. They should have 15 grams of carbohydrate or equal to one. I'm sorry. Yes, 15 grams of carbohydrates are equal to one carbohydrate exchange. And it depends on the patient as to how many exchanges of carbohydrates they get a day. They should avoid, obviously, high sugar, high carbohydrates, those simple carbohydrates, the candies, all the stuff kids like, right? Remember that those carbohydrates do turn to sugar in the bloodstream and when they're broken down. So educate the parents on blood glucose monitoring. Remember, normally our blood glucose is going to drop when we sleep at night. So we educate these parents to monitor these kids at least once a week between 2 and 4 in the morning when their blood sugar normally drops, because we don't want it to drop too low. And then educate them on the importance of adhering to their MD appointments and the follow-up. They may need to write down those blood glucose levels so that the doctor or the dietitian or the diabetic educator can get a good sense of what's going on. Keeping a food diary and helping them do a food diary and then adjusting according to what they're eating is also important. So some sick day guidelines. Well, we talked about that illnesses can alter blood glucose levels significantly by either causing hypoglycemia in some disease processes or hyperglycemia. If hypoglycemia, this patient could be dehydrated. If they're hyperglycemia, just the stress on the body of the illness or being in the hospital or even having surgery. So sometimes the insulin doses are adjusted and when they're sick, but children still require insulin. We don't ever stop giving them insulin when they're sick. So we're going to monitor those blood glucose more frequently. Instead of doing it every 3 to 4 hours, it's going to be every 2 to 3 hours. We don't want to tell them to stop taking the insulin when they're sick. We want to try and get them to still eat some food and those high protein meals as well. We're going to encourage fluids every 10 to 15 minutes. If the blood glucose is less than 200, we're going to tell them to give some sport drinks with sugar or some Sprite with sugar and regular Gatorade because it provides those electrolytes. If the blood glucose is greater than 200, we're going to give those same drinks but sugar-free. Your sugar-free Sprite, your sugar-free Gatorade, sugar-free Powerade, and your sugar-free ginger ale if they're nausea and vomiting, because we know ginger ale helps to ease the stomach and helps keep them hydrated. They need to have a couple of sips at least every 15 minutes or try with it. So check the urine for ketones when they're sick. You can see there's a little chart there. If the glucose or ketones is less than 100 and negative or small ketones, we want to give sugar containing fluids and hold the insulin. If it's moderate to large ketones and less than 100, we want to give those sugar containing fluids and some normal insulin doses. And again, if it's 100 to 199, and negative to small amount of ketones, we're going to give sugar containing fluids and the normal insulin dose. And then if it's 100 to 99 with your moderate to large ketones, we're going to give sugar containing fluids and give insulin 1.5 times the normal dose of what they normally get. And then greater than 200, we're going to again give those sugar-free fluids, normal insulin, and then give the insulin dose 1.5 times what their normal dose would be. Does that make sense? And why we're doing this, depending on the blood glucose levels, because they still need their insulin and they still need to be hydrated as well. Does anybody have any questions so far? No questions? All right. So let's look at diabetic ketoacidosis. What is it? How do we diagnose it? Well, some of the characteristics is these patients will come into the ER or to the hospital and they'll be acidotic when we do an ABG. We'll see their bicarbonates are 15 milliosmoles. The body is starting to break down fat. They get accumulation of the ketones in both the blood, the urine, and the lungs, which is what's going to, in the lungs is what's going to account for those rapid breaths and shallow breaths. Rapid onset, it does have a high mortality rate, so we definitely need to get these patients under control. It can be life-threatening depending on the severity and how high the blood glucose is. I have seen blood glucose levels working in the ER for many years, very high. You know, your glucose meter is only going to read up to 500. Other than that, it says greater than 500. So we definitely either way, we need to get a serum glucose level as well, but I have seen greater than 1,000 in some patients. They're very lethargic. Their respirations are very off. They're having those Kussmaul respirations, very fruity smelling breath. They're very, very sick, very lethargic, very altered level of consciousness as well. What are some causes of DKA? Well, they're not getting enough insulin. Their body could be too stressed. They could have poor glucose management, or they could be eating something that causes or contains a lot of sugar, or they're just really sick. A lot of times we see dehydration is the most common illness associated with DKA, and these patients are nauseous and vomiting. And they can have some pain as well. So we've got a lot of things we're trying to monitor and take care of with these patients that are in DKA. Signs and symptoms, your ketones in your urine, your fruity breath, the altered mental status, the dyspnea, nausea and vomiting, dehydration, and it can ultimately lead to a coma. Again, it is a medical emergency and it does require emergent medical treatment. These patients have a lot of electrolyte imbalances. They tend to have a very dry mouth. They could have frequent urination. So we definitely need to be monitoring their output as well, because we don't want to further dehydrate them on top of what else is going on. How do we diagnose it? Well, we get the urine and we'll see a lot of ketones in the urine. We'll do that finger stick blood glucose level, and it's going to be greater than 330. Electrolytes, we see hypokalemia and we see hyponatremia. That could go along with the dehydration as well, but they are starting to have some abnormalities. So what do we need to watch for if they're hypokalemic and hyponatremic? What body system can be affected? Y'all are quiet tonight.
The heart.
The heart. Thank you. Thank you. The heart. And hypokalemia can cause cardiac arrhythmias, and it can ultimately cause cardiac death, which we don't want. So putting these patients on the cardiac monitor is really important. We need to monitor their BUN and creatinine because they're going to start to get some renal dysfunction. And both of those are probably going to be elevated. When we look at an ABG, what do you think we're going to see? Is it going to be respiratory or metabolic, or is it going to be acidosis or alkalotic?
Acidosis.
Yep, which one? Respiratory or metabolic?
Metabolic.
Metabolic.
Metabolic acidosis, absolutely. What about their CBC? What do you think we need to monitor with that? Well, their white count for sure, because to see if they have an underlying illness. And also we can look at their H&H as well, because sometimes these patients drop their H&H as well. Pulse oximetry, what do you think we're going to see on a pulse oximetry? Is it going to be normal or low?
Low.
Low, absolutely. At least I have one person tonight. So what are some treatments for DKA?
0.9 insulin, normal saline.
Yes, normal saline. Good job. So normal
And then
saline replacement. I'm sorry.
and insulin.
Insulin, absolutely. We may do an insulin infusion for a blood glucose greater than 500. And the dosage of that is 0.1 units per kilogram per hour. So, and we're monitoring, if they're on an insulin infusion, we are monitoring these patients' blood glucose level at least every hour, and more frequently if we start to see signs and symptoms of hypoglycemia. So these patients need to be, the nurse needs to be pretty much with this patient a good portion of the time. It is an emergent patient. And good dosage calculations as well, because we're constantly adjusting the dose. Because if this, and the physicians in the pharmacy will send a range of where they want it. We're going to monitor those glucose levels every hour, like we said. The range, the target range for the blood glucose is 120 to 240. So you think, well, 240 is still high, right? But this patient was way high. So we don't want to drop it too low because they could be hypoglycemic. So we probably start off, depending on how high the blood glucose is, with some IV regular insulin until we can get that infusion started, because they can't maintain a high blood glucose for long. We're going to give them some potassium replacements because, again, remember, they could be hypokalemic as well. Monitor their urinary output. And then these patients might need some sodium bicarb if they're severely acidotic, typically less than 7.0 on the pH when we do an ABG. And then they may need some oxygen as well if they're extremely short of breath or dyspneic. So let's do some practice questions. A nurse is educating a teenager with type 1 diabetes mellitus on foot care. Which of the following client statements indicate the need for follow-up? So this is a select all that apply question. We have more than 4 answer choices. So ask yourself and go through each one of them. What do you all think? So I see some people just putting one answer choice. So again, remember, this is a select all that apply. Only 3 people are answering for us. Oh, there we go. Okay.
AD.
AB?
AD.
AD. Okay. So we're looking for answers that are basically incorrect, right? So I will moisturize between my toes to prevent cracks. So moisturizing the feet is good, but we're not going to do it between the toes. So that is a correct answer for this question. We don't want to do in between the toes because, again, remember, that area can breed infection and they might get some fungal infections because patients who are diabetic tend to get a lot of fungal infections. I think of fungus as being sweet, and if they're diabetic, they're sweet, they get a lot of fungal infections. Whoops, sorry about that. So B, I will never wear well-fitting shoes with nylon socks. Well, they always need to wear well-fitting shoes. So he does need some new or follow-up instructions on that. But we want to tell them not to wear nylon socks because, again, nylon does not breathe and they can get some sweaty feet. They can get some infections on their feet. And these patients more than likely have diabetic neuropathy as well, or the start of it, and it's got decreased sensation and they're not able to feel if they're getting any type of sores or injuries on the feet. We do want them to wear dry wicking socks or cotton socks. So A and B so far. We do want them to cut their toenails straight across and file the edges. Or see a podiatrist would be even better. I will only walk barefoot while indoors. What do y'all think about that one?
Go barefoot.
No, they cannot walk barefoot. We teach them not to walk barefoot, whether they're indoors, outdoors, anywhere, because of the incidences of the peripheral neuropathy. They may not be able to feel for any injuries, And if they have kids or grandkids around, you know, those Legos are horrible. And if they step on them. I will inspect my feet daily for blisters and color changes. Absolutely. So our answer choices for this question are A, B, and D. Does that make sense? Everybody see that? The rationale for those? All right, let's move on to the next question. A nurse is educating a teenager with type 1 diabetes mellitus on blood sugar control during soccer practice. Which of the following statements is accurate? So I see B and C here. The answer is
C.
C. They're going to drink a cup of orange juice before the soccer practice because again, remember, exercise is going to lower their blood sugar and we don't want their blood sugar to get too low, especially if they're out in the heat where they're going to sweat. They might become a little dehydrated. We do not want to administer half the dose because we're not going to have them adjusting. They should be monitoring if they start to feel lightheaded or dizzy or have signs of hypoglycemia. They definitely need to have a blood sugar checked. We don't want them to skip meals. And we don't want them to administer the insulin after the soccer game because then it's going to be too late and they've already exercised, their blood glucose could be low, and then they're going to take the insulin. I saw somebody asked in the chat to explain B on this question, so I'll go back to this one. So we do want them to wear well-fitting shoes, but we don't want them to wear nylon socks. So anytime an answer choice has two parts like that, and whether one or two is incorrect, or one part is correct and one part is incorrect, the entire answer choice is incorrect. We do want them to wear well-fitting shoes, but we do not want them to wear nylon socks because think about nylon. If you got socks on, remember the feet kind of sweat anyway. And these patients have peripheral neuropathy, so they may not feel any sores on their feet or problems. And we don't want bacteria or infection to occur in the feet and them not feel it. Does that make sense? But they have said never. What do you mean they have said never? I will never wear well-fitting shoes with nylon socks. They're supposed to wear well-fitting shoes. So this patient needs follow-up instructions because they're supposed to wear well-fitting shoes. Does that make sense?
Yeah. Because the nylon socks made the answer to be wrong. That is
Well,
why it's
so
the
did,
wrong
yeah,
answer.
they are supposed to wear well-fitting shoes, but the
Nylon
question,
socks.
right, nylon socks and never. So a nurse is caring for a 6-year-old client newly diagnosed with type 1 diabetes. Which of the following signs and symptoms should the nurse expect? Again, this is a select all that applies, so we have more than one answer choice that is correct. So I only have 2 people that answered. Let's talk about each of these. I have B and E and C and A. So secondary
C
enuresis.
and E.
I'm sorry,
I choose C and E.
you chose C and E.
Mhm.
Okay, you're getting there.
Mhm.
So, do y'all know what secondary enuresis is? So, this is an NCLEX term.
And A.
NA, you're correct. You are correct. But what is secondary enuresis?
You know, when a child that's supposed to have stopped peeing at a normal age later started peeing, maybe the child started peeing at like say when she was 4 and later started peeing when she's 8.
Well, secondary enuresis is the medical term for bedwetting. It's the diagnosis for bedwetting. So that occurs in those patients that were previously toilet trained,
Mm-hmm.
but that's a sign of a newly diagnosed diabetic. These patients start wetting the bed at night because of their blood sugar rising, and then they're not able to control their urine. Um, B, weight gain. We're typically not going to see a weight gain. We may see a weight loss in these patients. They will have polydipsia, and they will have, which is increased thirst. Um, Oliguria, they don't typically have oliguria. They'll have polyguria and too much urine, and then increased appetite as well. Oliguria means decreased urine output, and they're going to have increased urine output. So your answer choices are A, C, and E. Everybody see that? Okay. A nurse is caring for an adolescent with type 1 diabetes mellitus with a hemoglobin A1C of 4.7. What action should the nurse perform next?
C.
C, absolutely. Why C?
Because it's normal.
It's a normal
Because it's
range.
normal. Yep, absolutely. It's normal. We're not gonna it's within normal range because we said normal was 4.0 to 5.6%, right? So this patient, it's demonstrating excellent blood glucose control. So they're good, right? We're not going to administer normal saline. We're not going to give them insulin because if we give them insulin, then they could become hypoglycemic, and we're not going to give them glucagon because that's going to raise the insulin and the blood glucose. What do we give glucagon for?
When
To
the
put
blood
the insulin high, like to boost it up.
Not to boost it. Well, not when it's high. We
when
give
it's very
glucagon
low.
when it's
Very,
very
very
low.
low.
We want, yeah, because glucagon is glucose. We want to raise their blood glucose. So if they're hypoglycemic, we give glucagon, or we'll give D50, which is dextrose, 50% dextrose, which is sugar, and 50% water. A nurse is caring for a 5-year-old client with type 1 diabetes mellitus scheduled for an adenotonsillectomy. Which of the following preoperative orders should the nurse anticipate? Sorry.
B.
B as in boy.
D as in dog.
D is in dog. Yes,
Yep.
D is in dog. Yes. On the day of surgery, specifically in children with type 1, we want to give half the dose of the long acting, right? Because by time they're NPO, they're going to have surgery, an adenotonsillectomy. They should be done in about an hour at the very most, right? Those are pretty quick surgeries. And we want to make sure that that long acting, because of that duration of that insulin, that they're not going to become too hypoglycemic because they haven't eaten. And they're probably not going to eat anytime soon with that adenotonsillectomy. If they are, it's just going to be soft foods and like puddings and liquids to start with. We're not going to give a higher dose. We're not going to withhold it because they still need it. And we're definitely not going to give them sugar before the procedure, right? Because then we're going to make them hyperglycemic and have a whole nother problem. So the answer is D. A nurse is caring for a pediatric client with type 1 diabetes mellitus who presented with abdominal pain, fruity breath, and shortness of breath. Which of the following interventions should be implemented first? So this is a priority question. And when we look at priority questions, number one, we know because it's got the word first. And all of these answer choices can be correct. But which one is going to be the best one? So I tell
C.
students, think about
C.
which one of these
C.
which one of these answer choices is gonna save this patient right now.
C. Answer C.
Answer C.
C.
Yep.
Yes, that is correct because we give saline first. We want to do fluid resuscitation in these DKA patients, and a lot of times pediatric patients are automatically present with severe dehydration. And pediatrics are vulnerable populations. If they become dehydrated, they don't have as much circulating blood volume as an adult does, right? So we need to keep them hydrated. So C is the correct answer choice. A 14-year-old client presents to the emergency department with severe abdominal pain, fruity breath, and increased thirst. The serum potassium level is 2.9. Which of the following interventions should the nurse perform next? So again, this is another priority question.
B. B
B.
as in boy.
Yes, B as in boy. We are going to put this patient on a cardiac monitor because that 2.9 is really low, right? And this patient is 14. So they don't compensate as well or as easily as adults do. And children tend to deteriorate very quickly. So definitely he's going to go on the cardiac monitor so that we're monitoring him to make sure that we're not having any of those cardiac arrhythmias. We may or may not put in an indwelling urinary catheter. There's other things that we can do right now with patients and monitor their I's and O's. Give me just a second. They're calling me. Well, no, he's not. Okay. So we may administer some regular insulin infusion as prescribed, but not before we deal with that potassium. Because when we're talking about blood glucose being high and potassium being low, this patient is way at risk for some cardiac issues. And we may get an arterial blood gas, but we don't need that right off. We already know something's going on with this patient, right? So a nurse is educating student nurses on diabetic ketoacidosis. Which of the following clinical manifestations should be included in the teaching? And this is a select all that applies. So again, we're going to have more than one answer choice.
A, C, E.
Very good. A, C, and E. Absolutely. A lot of times these patients do develop some abdominal pain, and that could be due to the electrolyte disturbances as well. They are going to have some ketonuria, and it's going to spill over into the urine. I'm sorry. And they are going to have that acetone or fruity breath. Is somebody trying to ask a question? That what's with that pH? Is that something to be concerned with?
No, it's normal.
It's
It's
normal.
normal.
Absolutely. Yep. Yep. So recognizing the normals and the abnormals is also part of what NCLEX is going to test for. So our answer is A, C, and E. A nurse is educating a group of nurses on diabetic ketoacidosis. Which of the following are potential risk factors for this condition? Again, it's a select all that apply.
I'm choosing C and D.
C,
A
D,
and
and
C.
E.
Okay. I hear A, I hear C, and I heard E.
C, D, E.
C, D, E. Okay, so let's talk about these. These are risk factors for diabetic ketoacidosis. An insulin overdose is not going to put this patient in diabetic ketoacidosis. They're going to be hypoglycemic, right? An insulin overdose is too much insulin. And what does insulin do? It lowers the blood glucose level, right? So A is not correct. Steroid therapy absolutely can put a patient in DKA. Absolutely. Remember, steroids raise the blood glucose levels. I'll give you an example, and this actually happened to me. I had I don't have diabetes, but I had a issue with my eye, and my optic nerve was very narrow and was very swollen. I started seeing floaters, and I went over to the doctor because obviously it's an eye, and they told me my optic nerve. So for 4 days, I had to take a gram of Solumedrol IV for 4 days. Well, I don't. That put me into DKA, and it was a short period, and it also made me septic. But that's just as a example of how these steroids can affect patients. Thank God I rebounded. I was on an insulin infusion, but I don't have diabetes. But I was in ketoacidosis because of the steroids. So it can absolutely, even if somebody does have diabetes, it's triple the effect once they're taking steroids. Steroids are good. We use them for a lot of things, but we have to monitor those side effects. So that bought me, it cleared up my eye. Thank God I've never had a problem again, but it bought me a 5-day stay in the hospital because I was exhibiting all of those signs of ketoacidosis. Recent infections can also be a risk factor for diabetic ketoacidosis, especially if they are diabetic patients. fasting is not going to put them at risk for DKA. Fasting is going to put them at risk for hypoglycemia and then insulin pump failure. So how do we manage as nurses? How do we manage insulin pump failure? What do we do? What do we check for? So
You
we
check
want to
if
make
that pump, if the pump is functioning accurately.
right. Make sure the insertion site is not kinked. We want to make sure that the pump is working. We want to make sure that the line from the pump to the body is not kinked. Absolutely. Somebody put in the chat, I see, why not D? So think about that for a minute. If we are fasting, are we going to be hyperglycemic or hypoglycemic? These patients are more at risk for hypoglycemia. They're not going to be hyperglycemic. Does that help? Did that answer it? Hypo, yes. A nurse is caring for a child with diabetic ketoacidosis and notes the symptom small respirations. Which of the following best describes this symptom?
B.
B.
B is in boy.
Yep.
So it's actually D. They may be rapid, but they're going to be deep and they're going to be labored because their respirations are going to be very irregular and they may be taking deep breaths. They may be taking rapid deep breaths as well, but they are having some labored breathing. Irregular shallow breaths are not going to be shallow because again, they are going to be deep. They can be rapid, they're labored. These patients definitely need some oxygen more than likely to start off with as well. So those are my references. Does anybody have any questions or need clarification on anything? So this is the time for you all to ask questions or seek clarification on anything. NCLEX loves diabetes. I'll just say that. Nobody has any questions? Was that helpful?
Yeah.
Yes.
Yes. Yeah, so helpful.
Okay.
Yes. Thank you.
Yeah.
Does anybody have questions about any of the content? When are
I
y'all
tried
taking
to
it?
I tried to launch in before your lecture, but I couldn't launch in. I don't know what happened.
So I was having some technical difficulties and getting the PowerPoint uploaded. We were having some technical difficulties.
Not actually your class. Not actually your class. The previous class before your class.
Oh, I'm not sure about that one.
Oh, I couldn't log in either. Yeah.
So that is I don't know if Mr. Fermany is on here.
Yeah, the
The class
for
supposed to set up
for
at
7 o'clock.
7.
For
Yeah.
7.
Mm-hmm.
Was it on at 7 or
No, it wasn't there. Nothing.
Okay. So I can send them a message if you were having difficulties. I know for this class I was having difficulties logging into this system. And I was on with the tech support for almost 2 hours.
Mm.
But we did it and we got it.
Yep. I'm testing next week, Wednesday.
I'm sorry, you're what?
I'm
Good
testing
luck.
next week, Wednesday.
You're testing next week? Okay.
Good luck.
Thank you.
Clarification. DK, somebody put something in the chat. Let me see. Clarification, DKA is associated with hyperglycemia. Yes, it is. So good luck on your thing. Some test taking strategies.
Mm.
Make sure you read all the answer choices, right? Again, NCLEX is gonna make sure that you're a safe nurse. They don't care that you know what DKA is, but they're gonna give you a scenario about a patient who may be in DKA, and they're gonna ask you, what are you gonna assess? What are you gonna do? Intervene? What cues do you recognize? What actions are you gonna take, or what are you gonna evaluate? When we're talking about DKA in particular. Any disease process actually or medication, that's what they're going to ask about. It's going to be part of the nursing process, or those clinical judgment models, which are recognizing cues, hypothesizing cues, taking action, evaluating cues. What is it that you're seeing and doing related to whatever the content is? Any other questions? NCLEX likes pharmacology, y'all. They
Yeah.
like pharmacology.
Mm-hmm.
18% of the NCLEX questions are pharmacology. But, you know, they have your NCLEX categories. You got basic care and comfort, you have pharm and parenteral, and you have risk and reduction. You have physiological adaptation, you have psychosocial adaptation, but they could ask you a question that falls under any of those categories and it's related to a medication. So for a psychosocial, they can ask you a psychosocial question related to a medication, a risk reduction question related to the administration of a medication, because that's where most of the errors occur with med administration. They could ask you basic care and comfort. What do you do for a patient who's in pain? What's the best analgesic to give? But it would fall under basic care and comfort, but it's talking about a medication.
Mm-hmm.
Somebody put in their next class and time. Are you talking about next class I'm doing? Because there's classes pretty much all the time. You have to check the schedule. My next class is tomorrow night
Tomorrow.
I'm sorry?
Your class is tomorrow.
My class is tomorrow at 9 o'clock, and I'm
Nine.
doing medications for mental health.
Okay. Thank you so much.
You're welcome.
Thank you. This is my first time joining the class, and I'm so glad.
Oh, good. When do you take NCLEX?
I'm taking it on the 29th of this
Okay.
month.
So that's coming too. Good. Good. Where do you live?
I'm in Canada.
Okay.
Welland,
right.
yeah.
I live in Georgia,
Oh, you live in Georgia? Where in Georgia?
Covington.
Okay, I live in Peachtree City,
Okay.
and I
I
teach
live
full-time
in
in
Kenya.
Clarkston.
You
I
teach?
said, and I teach full-time in Clarkston. I'm sorry,
Okay.
somebody said something.
I'm joining from Kenya.
Oh,
Kenya,
wow.
wow.
Welcome.
Welcome. What is your time difference?
Probably, I don't know, maybe 8 hours or so. I'm not sure. I just woke up early today, a bit early.
Okay. It's 10:30 at night in where I'm at in Georgia.
Yeah.
Here is 5:24 in the morning.
Oh my goodness, that's early.
5 hours.
So, some studying tips for y'all. Are y'all practicing questions every day?
Yes,
For
please.
for those of you that are taking it?
Yes.
Yes,
Yeah.
please. I am.
Yes. Okay, good. You really need to be practicing questions. It doesn't necessarily need to be on particular content. It just needs to be practicing questions to get used to taking them, especially if
Mm.
your native language is not English, first off. I know a lot of times students will say they have to interpret it into their language and then translate it back into English in order to understand it. So, taking your time, reading the questions, and just practicing them will help you be more proficient. Remember
Okay.
your select all that apply, have more than one answer choice, and ask yourself, does this make sense for what this question is asking?
Mhm.
Also, your priority questions are all correct answers, right? But what is the
Mhm.
one thing you're going to do right now to help this patient with whatever condition or disease process or medication that they're talking about in the stem of the question? Make sure you're reading the questions and picking out those keywords, because your questions are going to have, they're always going to have a nurse, they're always going to have a patient, and they're always going to have a content, whether that content be a medication, a disease process, a teaching point, or you need to do more teaching, or you need to provide safety. What is it that whatever that content is, it's whatever that nurse is going to do for that patient that's listed in that
Mhm.
question.
Okay. Thank you.
Any
Mm.
other questions? Come on, y'all. You got 30 minutes.
Please, if I may ask, I just want to know the difference between this. What's if there is a condition, maybe the first thing to do and the priority. Is priority
So,
the same as first thing
right.
to do?
So if it says what is the first thing the nurse is going to do, it typically
Mhm.
doesn't word it like that. It typically will word it the nurse will do such and such first. Priority, that's still any of your priority questions will be first, next, immediately, priority. Those are all your keywords for your priority type questions. Immediately, I'm trying to think of all the other synonyms that they use. Immediately, first, next, priority. Pretty much those are the main words that they'll use. Those are all, we call those questions all priority type questions.
Okay.
Teaching, remember when you're answering priority questions, think of airway, breathing, and circulation, and think
Mm-hmm.
of the nursing process. So,
Okay.
if it's an airway problem, but don't get too tripped up. Make sure you know the difference between an airway and breathing, because a lot of times students will answer, and there will be, if it's talking about a patient who's having a breathing problem like an asthma is not an airway problem. Asthma is a breathing problem, but you're
Okay.
probably going to see some answer that has to do with airway, and students will, inadvertently or human nature, go pick that. So make sure you're reading it. If it's talking about epiglottitis or croup, that's an airway problem, right? Because they have a narrowed airway. They're not getting the air through. So then you're going to do something to keep that airway, right? Maintain that airway, whatever you need to do.
Okay. Thank you.
No other questions. Any?
Ma'am, I have one question.
Sure.
You said epiglottitis is airway issue. There was one more condition that you said. I just missed that part.
Croup.
True. Okay. Thank
Yes.
you.
Yes. Joining from Qatar. Wow. That is far away from me. Do you guys have any questions related to the NCLEX exam? Or test taking strategies?
Ma'am, excuse me.
Sure.
Borderlines, good to take NCLEX, maybe more of borderline than high.
I didn't catch you. What more
I,
borderline?
yeah, I said when you're getting more of borderline, not in readiness, other, other other que- other
The
question banks, when
questions?
you're getting more of borderline, are they good to take NCLEX? Your regular questions, 85 questions, you do practice
Right.
questions.
Okay.
Yeah.
So NCLEX is an adaptive exam. So there's a threshold that they want you to pass. So if they'll give a lot of people cut off at 85 if you stay above that threshold. They'll give you the 85 questions and it'll cut off. If you're staying right around that line, they're going to give you more questions related to whatever content that you're struggling with. So say it's respiratory. I'm just throwing something out there. If you're staying on that line with respiratory questions, they're going to keep giving you respiratory questions to try and get you above that line. If you're staying at that line and you're getting a lot of the same type questions, after a little while, they'll give you another content. And again, if you're staying at that same border, they'll keep giving you questions to try and get you to get high enough to pass. That's what's considered like an adaptive test. It kind of adapts to your knowledge. If you're way below that borderline or stay at that borderline, it may cut off again at a lower number. But the minimum that you're going to get is 85.
I think her question was
Yeah.
when we are practicing with the rat questions,
Okay.
And then if we have only borderline, for instance, my is high, but sometimes when you do one, you get like a 57, they say borderline. So she's asking if she is safe for that for the NCLEX. I believe that was the question. If I'm not.
Yeah,
Oh,
you're right.
okay. I'm sorry. I misunderstood the question. I would have to look into what the actual number is. But if it, how does it, is it like a predictor test?
Yes, you have high,
The
very high.
readiness one.
Yeah.
Okay. And so
I
it's
think they
telling you you're
say, I think they say you're supposed to have 70%, like very high,
right.
Mm-hmm.
Right.
to be
I think it's
comfortable for the
7 or
NCLEX.
higher.
Yeah.
Yeah.
So if it's borderline, it might be borderline to me means
50
that it,
something when you are on your 50, 52, 53 is always borderline.
57,
Mm-hmm.
58, 59. All those
okay.
stuff.
Like me, my last test, they give me a lot of BMI. They keep give it to me until the
did
test
they?
stop.
Okay. So maybe that's something you might need to go back and review a little bit.
Yeah.
What was it in relation to one particular thing with BMI, or it was just
They give it to me like if someone the BMI is the number, they just put a number what you're supposed to give. And after they give it to me, they say a patient was pregnant and the BMI is this. What we're supposed to do? They keep BMI until finish.
oh my gosh. So they like, the other thing NCLEX likes is all of your signs. Like McBurney's point. That's for appendix. Your rebound tenderness, that's for appendix. Those kind of things. They like to test on those too. In most
Thank you
practice
so
question
much.
panels,
Thank
getting
you.
borderline unlikely. I would have to look into their definition of borderline. To me, borderline means you're right there, but you don't want to be right there. Like I want to be above if I'm gonna take it, because I don't want to have to stress. But I will look into that. I'm not real sure what their definition of borderline is.
Okay.
Thank you.
You're welcome.
Thank you.
I'm here if you guys have any questions.
I have a question.
Sure.
Under diabetic, I see something today. I see a question talk about down something is when the blood sugar is up, and I think in the morning.
So
Down phenomenon, something like
I'm not
when the blood sugar is high in the morning, and another one say the blood sugar is low in the morning, I think. One of them is Simoji, something like that, and the other one was down phenomenon, something.
Yeah, Down phenomenon. I have read somewhere that it happens at 2 a.m. and the
Yes,
blood sugar drops
right,
down.
right. That's when the blood sugar normally drops. That's why in patients who are diabetic and have and take insulin, we tell them to test their blood sugar at least once a week between 2 and 4 a.m.
Okay,
Oh,
thank
okay.
you.
So you might get a question on NCLEX that has to do with that. And because it is the down phenomena, what time would you educate the patient to test? Or they may give you the patient states, I'm going to test my blood sugar at 9 a.m. I'm going to test my blood sugar at 10 p.m., you know, something related to that.
Okay, thank you.
You're welcome. I just want a clarification on the NCLEX scoring. Repeat test takers are not scored differently from first time takers. Again, it's an adaptive test, so it's going to give you questions to try and help you pass in a content area that you might be weaker in. If you're doing good on a content area, it may only ask you 1 or 2 questions. Happy to be here. I'm glad you're happy to be here. I'm happy to be here to help. It's my passion. Thanks, coach. I don't know that I've ever coached anything except nursing school. But thank you. You guys are a quiet group tonight.
Thank you and bye-bye. See you tomorrow night.
Okay.
Alright.
I'll see you tomorrow night. They just sent me an email about the earlier session. There were computer issues and the instructor experienced a power outage and a bad storm. So that's why you were having issues, if you were having issues logging into the first session. All right, well, if nobody else has any questions, it's okay, we understand at times, yes, at times it is inevitable, absolutely. Still on the NCLEX, what are the required to know for fundamental? What do you mean fundamental? Like the fundamental part courses in nursing? I had a below in it. So to me, fundamentals is your basics, your vital signs, your safety, your body mechanics, skills, all of those things that you take in that very first nursing course when you were in nursing school. Elimination is a content. Fluid and electrolytes is a content. Respirations is a content in fundamentals that most courses teach. Is that what you were asking? You were confused? Okay. So fundamentals goes back to the very basics. Your basic skills, how to put in a Foley catheter. Think about what's the one thing? Let's talk about a Foley catheter. What's the one thing that you want to ensure that you do when you're putting in a Foley catheter to keep this patient safe? What do we want to prevent? Infection.
Infection.
Absolutely. So how are we going to prevent that infection? We're going to use sterile technique to put that Foley catheter in. So we're going to maintain that sterile technique. Absolutely. Absolutely. Sterile technique. So think about when you were in the skills lab, you went through all these steps, but donning the sterile gloves, and then that could fall under safety because infection by sterility technique. Absolutely. Because we want to keep that patient safe. That could also be a risk reduction because we want to reduce the risk of infection for that patient by maintaining sterile technique. NCLEX likes personal protective equipment as well. So what is standard precautions? What patients go under airborne precautions? Anything that can be airborne. So those patients may go in the negative pressure room. Well, if nobody else has any questions, I'm going to end it. A deep insight that is helpful. I'm glad it was helpful. Well, I hope you all have a good night. And for those of you that said they're going to be on tomorrow, I will see you tomorrow.